So good morning, good afternoon, and welcome to this webinar on challenging of managing patients with osteoporosis during and after the COVID-19 pandemic in Europe. I'm Dominique Pierrot, Science Manager at IOF, and today I have the pleasure to welcome Professor Nicholas Harvey from Southampton, Professor Thierry Thomas from Saint-Étienne, and Professor Adolfo Diaz-Perez from Barcelona. Before giving the mic to Professor Harvey, I would like to let you know that attendees are automatically muted. I also would like to encourage you to ask questions during the webinar by typing them into the question box of the GoToWebinar control panel. Professor Harvey will voice them to the speakers towards the end of this webinar. This being said, I'm very happy to introduce our moderator of the day, Dr. Nicholas Harvey, Professor of Rheumatology and Clinical Epidemiology at MRC, University of Southampton. He is also the chair of the Committee of Scientific Advisors at IOF. Professor Harvey, the mic is yours.
Thank you very much, Dominique. And I'd add my warm welcome to all of you, and thank you for joining us on this webinar in which we examine the challenges of managing patients with osteoporosis during and after the COVID-19 pandemic in Europe. And as chair of the IOF Committee of Scientific Advisors, it's a huge pleasure to moderate this webinar and to introduce our two expert speakers, Professor Thierry Thomas, Professor of Medicine and Head of the Rheumatology Department at University Hospital Saint-Étienne in France, and Professor Adolfo Diaz-Perez, Head Emeritus, Department of Internal Medicine and Infectious Diseases, Hospital del Mar in Barcelona, and Professor of Medicine at the Autonomous University there. So without further ado, I will hand over to Professor Thomas to tell us about his perspective on some of the issues that we faced in terms of treatments, bone density, social distancing, and so forth. Professor Thomas, I look forward to what you have to tell us. Thank you.
Thank you, Nick. Thank you for this introduction. Hello to everyone. So here are my disclosure. What I will have to do during this coming 15 minutes is to cover the management of patients, especially patient visiting FLSs. That is a major activity in managing of osteoporosis, of course, and that's probably the one that was more severely impaired by the pandemic. Of course, the first step of a journey of a patient with an osteoporotic fracture was not changed by the pandemic. The patient arrived in the emergency room. Some of these ER were split in two different areas were for patient COVID plus and those that were without any additional disease. But this step was okay. And the next one in the operating room was also well covered in all hospitals. But the journey was then very difficult for our patient during the pandemic, because at least in my country, and I assume in most areas in Europe, we were not able to pursue our activity in fracture liaison services, because we were not able to continue to have DEXA and visit of patients with a bone specialist. The communication between the different departments were really focused on COVID patients. All the departments that were managing usually the fall risk were also dedicated for COVID patients. So all these organization was probably stopped in most institution, as it was in mine. So I will emphasize in the coming slides what we propose in the Capture the Fracture program and websites. Was kind of simplified procedures that were able to continue to manage this patient without the formal organization of a FLS in these exceptional circumstances of stretched hospital systems. What is very important in our view was that we needed to establish a pathway in the orthopedic centers, and we have to keep that in mind for further situation that will push us to again stop our FLS organization. And of course, we have to keep that in mind if there is a second wave on the way, which I do not hope, of course. But what is very important is to initiate an appropriate osteoporosis therapy to our patient, and probably the best way to do that in these circumstances is to do that before discharging the patient from the orthopedic ward, at least for all patients that are eligible for those treatments that are above 65 with a major fragility fracture of the hip, the spine, the humerus, or the pelvis that are the most severe fracture related to osteoporosis. And there is certainly no need for a DXA scan at that time. And the only limitation to introduce the treatment is the absence of contraindications. To be sure that there is no contraindications, there is a need for a minimal blood test, but that can be limited to a normal serum calcium level, the absence of vitamin D deficiency, and of course, no renal insufficiency with a creatinine clearance that has to be above 30 or 35 milliliter per minute, depending on the drug that will be given to the patient. Then when the lockdown has been shut down, there is kind of a return to normal activity. And to do that in the appropriate way, we have to keep a list of those patients with fragility fracture that were not appropriately assessed during a visit in the FLS for a further evaluation. And ideally, this has to be done within 6 months after the fracture, especially because giving an anti-osteoporotic drug is one important aspect of managing osteoporosis, but there are several other aspects that have to be covered as well, including nutrition, risk of falls, databases, and so forth. When the hospital services restart, we have to be proactive to recall the patient and get them access as soon as possible to DEXA and a VFA evaluation, of course, because that may change, for example, the choice of the treatments we're going to use. One of the reason there is this need of having an alternative pathway within the orthopedic ward during the pandemic was that we have to face the problem of the imminent risk of a second fracture in in those patients who have the first major osteoporotic fracture. And if we want to rapidly reduce the risk of this second fracture, there is a time frame that is of course quite limited, because there is this very high risk of a second fracture during the first 2 years following the first one. So that's a big issue in this situation of the pandemic. As I said, initiating medication is only part of a global therapeutic strategy. And if we want to have a good adherence of the patient to the treatment and a good compliance to that, we have to change the patient from a reactive position to a more proactive position. And that's probably a difficult task to achieve if the patient is just started in the orthopedic ward. And that's probably where the teleconsultation that Adolfo will describe in his presentation, that will be very helpful to emphasize the need for a more balanced diet and the measures to prevent falls, for example. Then coming to the treatment choice, if it is initiation of therapy, ZOL can be easily given even within the 2 weeks after a hip fracture if the patient is eligible to this drug. And there's certainly no solid data demonstrating that giving the shot of ZOL during these following days after the fracture is not as efficient as doing that later on. What is important to keep in mind for the patient as well as for the medical and nurse team in the orthopedic ward is to pay attention to the flu-like syndrome, especially in these circumstances of the pandemic. A fever may occur shortly after the ZOL, and that has to be prevented by the use of paracetamol, for example. If the choice is DMAB, a special attention has to be paid to appropriately schedule the next dose of DMAB. And again, that could be easily done if a teleconsultation is scheduled after the patient leaves the ward. Another option, of course, is to start a treatment with an oral bisphosphonate that is probably more easily to handle. And then if the patient has the right profile, then a teriparatide can be introduced, but that may need a brief self-injection training, because of course during the lockdown it will be difficult for a patient leaving the ward to find a nurse to do that in his home. If the situation is now treatment renewal, especially for patients under IV or subcutaneous drugs, there are some aspects that have to be well managed. For teriparatide, there is no rebound of bone cells activities, and there are data from clinical trials showing that there is a sustained decrease in the risk of fracture following treatment withdrawal. However, there is no persistent biological effect of the drug after the teriparatide is stopped. So if because of the pandemic, the choice is to change teriparatide to another drug, and especially an anti-resorptive agent, this has probably to be done within a short time frame of 3 months. For DMAb, the situation is quite different because there is a very adjustment period narrow beyond 6 months after the previous injection. As you know, the effects of the drug will quickly dissipate with a rebound in bone remodeling that will occur within a few weeks. So if DMAB next injection has to be postponed, this should not be beyond 1 month after the regular time frame. For Zol, it's much easier because we know that the infusion can be easily postponed for 1 to several months. Of course, with the pandemic, we learn day after day, and there are still a lot of unknowns on this pandemic, and especially on our patient with osteoporosis. For example, we don't know whether the risk of mortality following a major fracture in patient that had COVID within 3 months after fracture, even whether this risk will increase, combining the occurrence of the fracture and the occurrence of the COVID. We don't know whether the risk of major fracture will increase if osteoporotic patient had a COVID. We don't know really whether social distancing and self-isolation circumstances will increase or whether decrease the risk of falls in our frail osteoporotic population. We don't know really whether this self-isolation will change the compliance to treatment. And we don't know really whether anti-osteoporotic drugs will have the same safety during the pandemic they have in normal days. They can increase the risk, or they can even decrease the risk of pulmonary infection. And I will just quote a very interesting and intriguing paper published this morning suggesting that aminobisphosphonates may decrease the risk of this infection, and not specifically the COVID, of course. So all of these, to me, are very interesting matter of research for the future. And with that, I will give the mic to Nick back. Thank you.
Wonderful. Wonderful. Thank you so much, Thierry. That was a really nice start to the proceedings, and I'm sure that will seed plenty of questions as we go forward. So just to say that feel free to type in questions at any point, and it's good to see that starting. And we'll go through the questions as a sort of panel discussion at the end. And before I'll hand over to Adolfo in a minute, and I'd just like to reiterate my thanks to both speakers and also to Amgen, who are supporting this webinar today. So with that, I'll hand over to Adolfo Diaz-Perez to take us through the second part of our webinar. Adolfo, over to you. Thank you.
Thank you very much, Nick, and thank you very much to the IOF also for giving me this opportunity. Next slide, please. These are my disclosures. And we will review briefly some points of clinical assessment, an overview of the remote consultations telemedicine field, few words on self-injection of drugs, and also the changes in practices for healthcare practitioners. Next, please. And nothing better for starting that going to a real-life patient. This was a patient of mine, a 60-year-old lady with a history of multiple fractures and scoliosis. She was on weekly arlandronate for 4 years, but she got 2 new fractures while on treatment and then was switched to Denosumab subcutaneously 23 months ago. So she has received a total of 3 doses at this point. This is the spine film. Next slide, please. And this is the DEXA historical of the patient at the moment when she was switched to the subcutaneous regime with Denosumab. Next, please. Then this patient came to the hospital with a referring 5 days of fever, up to 38.7, dry cough, general malaise, a mild diarrhea. The oxygen in peripheral blood was normal, but in the chest rate, there was a mild basal infiltrate. And the PCR for the COVID-19 was positive. And at that point, the next dose of the Denosumab was scheduled in 2 weeks' time. Okay, let's stop here. Next, this is a good patient to start thinking on the new field of remote consultation, telemedicine, or telehealth. Next, please. What we are facing now is that COVID-19 has transformed this modality of healthcare into an essential service because it has changed the paradigm of face-to-face visit, leading to an increased adoption of telehealth because of the distancing circumstances. And what we mean by telehealth? Telehealth is the interactive electronic exchange of information for diagnosis, intervention, or ongoing care management, all of this remotely, and is quickly expanding during these pandemics. Next, please. And telehealth has 3 arms: telemedicine, strictly speaking, the possibility of remote patient monitoring, and also the so-called mHealth or mobile health. And telemedicine can be practiced in a synchronous or asynchronous way, depending that if the interactions are in real time or are in some way delayed. Next, please. Next slide. There are obvious advantages of this modality of healthcare. It permits you to do remote triage, remote surveillance. It allows the continuity in the management of chronic diseases, keeping the face-to-face visits only for the sickest patients, decreasing the risk of person-to-person transmission, and keeps the healthcare workforce safe, and also allow physicians that are symptom-free but in quarantine due to the pandemics to provide patient care remotely. And of course, relieves the strain on the local healthcare workforce, hospitals and primary care centers, etc. Next slide, please. And what is meant by telehealth? Telehealth is the interactive electronic exchange of information for diagnosis, intervention, or ongoing care management remotely. Go ahead. Next. And there are several modalities: real-time virtual interaction, remote patient monitoring, and synchronous store and forward. Next slide, please. With respect to the interaction between the patient and the physician, the nurse, or any healthcare provider, you can schedule virtual visits. You can use also the help of wearables and home exams, and use also secure messaging. Next slide, please. There are several potentials for this patient-provider interaction, like the video visits, the use of telephone, text, email. Some applications provided by the mobile phone, or the applications of voice interface like the ones for Amazon, Google, or Apple, the use of mobile sensors like smartwatches, wearable devices, chatbots, or organizing and expanding the services of the hospital at home. Next slide, please. Next. This is a very recent example of a chatbot that was articulated in a US center in response to the needs, to the increase and rocketing needs of healthcare using chatbot, where you can manage a lot of questions, providing meaningful answers to the patients through use of this scheduled dialogue system. Next, please. And the interactions between providers can be also be done by telehealth, by electronic consults between different specialists, or the use of implantable and asking for a second opinion about a given clinical problem. Next slide, please. What about telehealth and specifically osteoporosis? Next. There is a web page provided at the website of the IOF that gives you some very useful tips and advices for patients and healthcare providers during these pandemics of COVID-19. I strongly advise to visit that. For the clinical assessment, by using telemedicine, telehealth, you have to use the classical tool of anamnesis, recording family history, previous fractures, the risk factors, both modifiable and non-modifiable, like age, gender, physical activity, falls, etc. And also, importantly, during that pandemic, is checking for the aspects of social support, isolation, pain management, depression, etc. And also to explore the comorbidities. Next, please. One of the extremely useful tools to being used by telemedicine is this extremely well-known questionnaire that is FRAX, that actually is able to profile you very well, the patient, by the personal family data and also comorbidities and risk factors, and then is able to classify the risk of future fractures, both major osteoporotic and hip fractures, in the individual patient. Next. Next slide. Remember that if the patient has sustained a fracture, a prior fracture is probably the most important risk factor, a future fracture, as Thierry reminded us a few minutes ago. And we can also integrate in the calculation of the risk, age, and other risk factors. And during this isolation situation, possibly low mineral density, bone mineral density cannot be measured and can be deferred for later on. Next slide. This way, we will be able to classify patients, to follow recent guideline updates, to understand and to know what is the risk level of a patient. Next. With these simple tools, we are able to collect most of the elements that profile a patient at very high risk when one or more of these is present. Previous fractures within the past 12 months, multiple fractures, or fracture while on treatment for osteoporosis or on medication harmful to bone, and also by using FRAX, when the probability for major fracture is above 30% of more than 4.5% for hip fracture. Next. The patient can be at high risk if there is a prior fracture, or if we know his or her T-score value before the current consultation. And finally, we can also classify the patient as a low, next slide, please, as a low risk if there is a postmenopausal women with no previous fractures and with a FRAX with not high probability of fractures, either major or hip. This way we can behave with more urgency or delay our measures for a later moment after the isolation. And for the follow-up of the patients that are ongoing in the care of the osteoporosis, we need to check for new or worsening symptoms, for the level of physical activity, falls, diet, and also for the level of social support and health, isolation, again, depression, very important, etc. Very crucial to check for the compliance to medication, renew or change prescriptions, and also to have a clear criteria for referring the patient to the medical center. Next slide. So in patients with osteoporosis, it's extremely important continuing therapy with established bone health plans. Next. In patients with new fracture who require DXA and lab tests to initiate therapy in normal conditions, we may consider alternate options for delivery of care. Next, please. Next. For example, DXA may not be needed depending on the type of fracture, hip or any of the fractures that Thierry referred to. We can also use online risk calculators for helping us in making decisions, like FRAX, Garvan, etc. Next slide. And there has been a SBMR panel in cooperation with other societies that has issued some guidance for the treatment of patients during this COVID pandemic. Next slide. And in brief, some important points to remember is that for Denosumab, you may consider a delay in treatment, but if the delay exceeds 1 month, then it's better if you consider a temporary transition to an oral bisphosphonate. For teriparatide, abaloparatide, or romosozumab, when available, you can also consider a delay of treatment, but in this case, you may transition to oral bisphosphonates if the delay exceeds 3 months. And for IV bisphosphonates, delays of even months is unlikely to be harmful. Next slide. What about our patient? Next, please. She recovered from the infection in no more than 6-7 days. Fever and respiratory symptoms disappear, and the Denosumab dose was delayed for an extra week. So in total, she got the injection 3 weeks after the scheduled date. And in this case, like is quite common in Spain and is licensed everywhere in the world except in USA, the patient was able to self-inject the drug. Next. And with this strategy of self-injection that is very easy to learn, there is no need to contact with providers, health facilities, other patients, etc., what is really relevant in terms of pandemics, because avoids the risk of transmission. Next slide. What are some future developments of telehealth? That is a very complex and promising field. Actually, these services are in very quick explosion in this publication for Health Europe due to the coronavirus. Next. And there is a very recent paper explaining in detail the artificial intelligence applications in medicine that has been issued by the Joint Research Council of the European Union, that is available for free in internet, that explains key points about the artificial intelligence that is actually the core component of telemedicine. Next slide. Because artificial intelligence is no more than a subfield of computer science where machines can imitate human intelligence. And it has been estimated that in the US only, these applications can save up to 150 billion in annual health costs by 2026. And in this report of the European Union, you can review the future applications, the fields to explore, as well as some issues, problems, and potential risks of the use of artificial intelligence in medicine. So in conclusion, COVID-19 has changed the paradigm of face-to-face visits with patients. The decreased access to physicians during COVID-19 highlight the importance of telemedicine to ensure care continuity and fracture risk prevention. But actually we are at the beginning only of telemedicine and artificial intelligence applications in medical care. Next slide, please. But always a fundamental point to remember that either in face-to-face or by using distance methods, you always need to be warm, compassionate, and close to your patient. Next, and with this picture of my hospital, right by the beach where our patients are taking huge doses of natural vitamin D, I would like to thank you for your attention. Thank you very much.
Great, thank you so much, Adolfo. That was really, really helpful. So we have time now for a panel discussion. Well, I guess with a panel of three of us. The questions are starting, they're flowing in, and we've got some really good thoughts here. I'd just like to start picking up on the point about Denosumab and the timing of Denosumab. We certainly don't want to be delaying Denosumab more than a month after the scheduled dose. But Adolfo and then Thierry, what do you think about maybe giving it a month early if that fitted with circumstances and avoided it being given late? So giving it at a 5-month interval rather than a 6-month interval for one particular dose.
Thierry or myself. Well, this is a good point. Although to me the challenge of advising the dosing is that you make these decisions once isolation, self-isolation, quarantine, or pandemics is going on. Therefore, it's difficult to predict in advance when this will occur. And given that we have options for following a more regular pathway of providing the dosing, I think that this advice of 2, 3, 4 weeks at the most, delaying the dose could be useful enough. And if you have to go beyond 1 month, then you add at least temporarily an oral bisphosphonate.
Yes, I fully agree with Adolfo. There's only one situation. If you know that a lockdown will occur within a couple of days, then you can certainly manage to do the next shot earlier in this time frame of 5 to 6 months. But in most circumstances, you'll be on the other side around.
Absolutely, yeah. I would think it's an atypical situation, being able to do something earlier than planned. Just continuing the Denosumab theme. I mean, it strikes me that with teriparatide, you're self-injecting every day for 2 years, and of course, if you mess up one injection, it's not so critical. But with Denosumab, if you've got one dose, you inject it every 6 months, and you have a problem with that could remove the drug for that 6-month period. Is that is that a concern in practice, Adolfo, or are the systems worked out such that it's a pretty reliable thing for patients to do themselves?
Well, my experience is very easy, and most of
Good.
my patients, they inject themselves, or in the worst case scenario, when the patient is very elderly or very limited, some relative or some friend injects. It's so easy that I have never seen any challenge of self-injecting the Denosumab.
Yeah, no,
Usually
good.
it's the
Well, that's
good
reassuring.
way to
Yes,
go.
Thierry, add to that.
Yeah, if the husband is still alive, it's certainly a good guy to do the shot.
Yeah, good. Thank you. So I guess there's a further Denosumab question related to PTH values. When do we expect it to come back to normal values after the Denosumab injection? Either of
You
you?
mean in terms of bone remodeling?
Yeah, I suppose it. Well, I suppose it's really around the changes in calcium concentration and effects on PTH, and when does that sort of immediate change in bone biochemistry come back to normal rather than the bone turnover markers?
Well,
I mean,
for
good.
PTH, the possibility of having a hypercalcemia, that you know that in the very vast majority of cases is mild and asymptomatic, goes back to the baseline in a few hours. If it persists, then you have to reconsider the treatment, and probably you have to check for concomitant treatments. For the Denosumab, the only potential challenge could be the other way around, hypocalcemia. And this is especially true in patients with chronic renal failure, is where you can see a critical decrease in serum calcium. In this case, again, you have to reconsider the vitamin D regime and also to check more carefully and eventually to change the treatment, providing supplements of calcium if needed.
Great. Thierry, did you want to add anything to that, or shall we move on?
Now we can move on. I mean, there is usually a short period of time during which PTH increases after the DMAP shot, and this also observed under bisphosphonates, but for a longer period of time. But it's not a problem actually.
Yeah, absolutely. Yeah. Thank you. So I think just switching to the other parenteral therapy that we've considered, which is zoledronate. And Thierry, you talked about the 2-week issue, and really that it wasn't an issue to give treatment before that. And of course, you know, we need to be very pragmatic about getting treatment into people after, say, a hip fracture before they go home again. Can you just elaborate a bit on that and just outline the state of the evidence around the timing of zoledronate after hip fracture?
This issue of this 2-week following the fracture event came from a post-hoc analysis looking at different time frame of injection after a fracture event in the Horizon Recurrent trial. And the only time range in which there was no decrease in the risk fracture that was observed was, in fact, these first 2 weeks after the fracture occurrence. But it was a post-hoc analysis, and there were very few patients that were in this specific time frame, and it was rather a problem of statistical analysis rather than a matter of pharmacological problem. And we have to keep in mind that the the way the bisphosphonates go to the bone matrix is mainly driven by their physical properties, and to me there is no way that ZOL will go only to the fractal location and not to the entire skeleton as it has to do. It's a very passive way of adherence to the matrix with the bisphosphonate, and especially the ZOL that is very adherent to the matrix.
Thank you. No, that's a really helpful perspective. Yes, Adolfo.
Yes, this reminds me to say that the best is enemy of the good. And during a pandemic, in very unusual circumstances, if you have a patient that has been admitted because of hip fracture, don't miss the opportunity of providing the sole injection even during the first days after a fracture, because later on can be really tricky.
Absolutely. Do not miss those opportunities to treat people, because they may well not get treated at all if we do miss them. I think that's a really important take-home message in all of this. So, okay, so what about Denosumab and the timing of Denosumab after a fracture or after surgery for a hip fracture? Are there any issues with timing then, or with fracture healing?
I think the time frame is really based on the time you need to do the blood test to get the answer of whether there is renal insufficiency or not, whether the calcium serum level is fine. So it's a couple of days, but that's really the problem. Then the DMAB is a circulating agent, and there is no risk to do that just a few days after the fracture.
There has been this topic is a recurrent discussion in the field for years. If giving an antiresorptive, and in particular a very potent antiresorptive like DMAB, can be deleterious for fractures. Besides some preclinical data, there is nothing, clinically speaking, of concern. And as we say 1 minute ago, treat your patient and don't worry that everybody will benefit from being covered from future fractures.
Absolutely, and I think the balance of risks is really important to remember, that in these situations the risk of a further fracture and the degree to which you can reduce that with treatment vastly outweighs the risk of any of these side effects or other considerations, and getting people treated has to be a top priority.
Yeah,
so
actually, to go on Adolfo's comment, actually it has clearly been shown that under antiresorptive drugs, actually you improve the osteointegration of any material you put in the bone to fix a fracture.
Yeah,
sure. You can increase the size of the callus, but mechanically speaking, the fracture is perfectly stabilized and the strength of the bone is greater.
Yeah.
Thank you. So just returning to your points, Thierry, about blood tests. One of the questions has come in saying, would you, in your minimal blood tests before therapy, would you do bone turnover markers?
In the situation of a patient just having a fracture, there is no need to do that, and there is no interest in checking biomarkers, because they will increase because of the fracture. So I would not rely on that. Actually, what is important for the biomarkers is to be sure that you have the pharmacological effect of the drug, and to be sure that at least under antiresorptive drugs, you're within the premenopausal normal range. So no, I don't do blood tests at that time, right after the fracture.
Adolfo, do you have anything to add to that?
No, I fully agree. Actually, the markers should be increased right after a fracture, so there is no any help in making decisions. So no need for measuring bone markers at this point. Later on, checking compliance may be useful, etc., but not right after a fracture.
Sure, absolutely. So I'd just like to return, I suppose, keeping on that theme of blood tests. The sort of level of 25 hydroxy vitamin D one is aiming for before commencing treatment, and I think the figure of 15 nanomoles per liter was flagged up. And I guess there's potentially a difference here in terms of say, starting zoledronate or denosumab compared with an oral bisphosphonate. And of course, you've got more time to get things up with an oral bisphosphonate. Can Adolfo, could you just comment on that and perhaps both on your approaches to vitamin D repletion?
Well, this is another pandemic. The high prevalence of low levels or even severe depletion of vitamin D in our population, in particular in our population with osteoporosis, and more so in patients with osteoporotic fractures. So supplementing with vitamin D is something that should be a routine. And doing loading dose is safe and is at least useful in restoring the normal balance of the hormone. And it has been also discussed if giving vitamin D might be useful for the COVID-19 infection itself. And just today, it appeared a review by the NICE, the National Institute of Clinical Excellence, saying that there is no evidence that could be of help in the COVID-19 infection, but at least can be helpful given the need for this treatment and the high prevalence of the deficiency.
Yeah, absolutely, and I think we do need much more robust evidence before we really start thinking of vitamin D as in any way preventative or therapeutic in terms of the virus. But for musculoskeletal health, it's absolutely essential, and particularly when we're talking about treating people post fracture with IV therapies. I completely agree. So I guess that there was just one question about bone markers in terms of how long after a fracture do we need to wait to get reliable results reflecting baseline activity? Just a quick answer from one of you.
It depends on the size of the fracture, but for big bones like the hip fracture, for example, the increase of the bone markers of the fracture may last for at least 6 months, and some studies showed that the increase were still there almost up to a year.
Great. So yeah, so really quite variable then, but some time and not a quick thing. So I we've got about 5 minutes of discussion left at most. I'd just like to touch on your thoughts for the future. And of course, we've missed seeing a lot of patients. And as you were saying, the ability to keep track of people that have not been seen that need to be assessed in the future. But of course, there's a massive backlog of people waiting to be seen, and we're now in sort of socially distanced situations. It's more and more difficult to see people face to face. So can you each just give some thoughts on getting back to a more normal clinical activity? How do we restart services, and how do we prioritize people to be seen, and who should do that prioritization? Adolfo, do you want to comment on that first?
Well, you have to, for sure, after the quarantine period, you will have a lot of patients piling up waiting for the face-to-face visit. Then is when you have to make priorities. And indeed, those with a recent fracture at very high risk or that have had a very severe problem in other aspects of medicine with other disease or whatever are the first priority. And for the others, probably you can schedule 1 or 2 interim visits over the phone or using internet and delay the live person-to-person visit for later on once the overload of the health system has returned more or less to normal levels.
Great, thank you. And Thierry, do you want to add to that?
Yeah, it's a difficult answer because it depends from country to country. And for example, in France, there is the need for physician visit or teleconsultation, but we have no opportunity of doing that with our nurses. So when a physician is on teleconsultation, he's not visiting patients. So we don't save time that way, and we have to think of different organization, either with more nurses that are involved in the management of the patient, or with a better network with the GPs.
Great, thank you. Well, I think we're rapidly running out of time. Thank you again so much to Thierry and Adolfo for fantastic talks, and thank you so much for your answers to the questions. Thank you very much to all of you out there for listening and for sending in such stimulating questions. The session is being recorded, so should be available in due course on the IOF website. And it just remains to thank very much the Dominique and those in the office for pulling this all together, and the very kind support from Amgen. So thank you very much from me, and I'll just hand back to Dominique to close out the session. Thank you.
Thank you very much. Thank you, all of you. Just for the attendees, I just would like also to let you know that you will be prompted to fill in a survey immediately after this webinar, as we would appreciate your input and comments as we continuously try to deliver webinars that meet your needs. If you have any questions, comments, please do not hesitate to contact us at webinar@iofbonehealth.org. And as Professor Harvey mentioned, the recording of this webinar will be posted on our website, and you will receive the link to the recording by email on Monday. And once again, on behalf of IOF, I would like to thank again Professor Thierry Thomas and Professor Adolfo Diaz-Perez for the excellent presentations, Professor Nicholas Harvey for moderating this webinar, all of you for your participation, and Amgen Europe for the support. And this being said, I wish everybody a nice weekend, and goodbye.
Bye now.
Bye.